So in the suture kit, they sent us a lot of monofilament suture. And I'll talk to you guys about some of the really, really common mistakes that are made in learning to suture, number one, and then number two, handling of the needles and so on. Okay. So first of all, one thing you'll know, these are packaged in loops. They're looped around and so on. So oftentimes, particularly with a monofilament, when you come out of the package, your scrub nurse, if you were lucky enough to have one, and most of us when we're young students don't, so we learn, you want to actually stretch the nylon and monofilament sutures so that the memory is out, so that they don't just go back to the coil that they were in before. All right. And it's odd to be suturing without gloves on, but we'll do that today because it's easier. Now, if you notice, there's a couple areas on the needle where I don't want to pick up the needle. You don't want to actually, can you zoom in, Mike? Mm-hmm. You don't want to actually grab back here where what's called the hub. This is where the suture actually comes in to the actual back of the needle right here. Okay. That's hollow. And so if you actually grab that with the needle driver, you can actually bend that and then the suture will actually break off. So you basically want to grab the needle in the middle third of the radius. But as you get more advanced, you can actually learn that you can hold the needle many different ways to help yourself in terms of how you suture. Okay. But in this case, we're going to do it very simply. We'll want to load it basically in the middle of the curvature. And the easiest way to think about it is if you turn your handle, it would turn towards yourself like so. And if you notice the needle has a curve to it, and we use that curve to actually help us sew, okay? And so in this case, we're going to start with the very simplest type of suture. And you'll notice that I actually put the suture in my hand and I'm controlling the tail of the suture back in my hand, right? And I don't have my fingers all completely stuck into the holes. You actually learn to palm the needle driver such that your fingers are easily in and out of these. And that's one of the things you can do without even doing sutures, is just learning to manipulate the devices, the needle drivers and the others. Now, as far as your pickups, which you'll use in your other hand, they're much like chopsticks. You use your long finger and your thumb for the pushing, and you control it with your fourth finger, and your index finger are controlling the different rotations. So you have essentially 3 and 4 finger control of your pickups to manipulate the tissue, okay? And oftentimes you don't have to pick the tissue up. You can actually push the tissue together and so on. So we're going to start with the simplest, or a simple interrupted suture. And you would come into that, and we're going to use the zigzag here. We're going to come into it, and one of the mistakes that's made often is people come too close to the edge. So in this case, particularly for simple interrupted, you're going to want to be approximately 1/2 centimeter back from the skin edge, right? You're going to want to use the tooth that's under the skin edge, and you can actually pick up underneath so you're not further compressing and damaging the skin. You can actually pick the skin up with the tooth, and so you're not actually squeezing and compressing. The needle.
Dr. Corey?
Yes.
There is a question. Faison wants to know which you use your dominant hand for.
Your dominant hand?
Yeah, which one's supposed to be your dominant, and which one's supposed
hand would be
to be your non?
Your suturing hand, because you've got the sharpest thing in your suturing hand. And essentially, much like chopsticks, you push stuff around with your chopsticks a little bit. The same thing, your other hand becomes almost a post that you're working against. So your hand that you'll use your pickups in is usually your less dominant hand, and you'll use that to essentially stabilize what you're pushing against. So in this case, if I'm going to go to the far side of a laceration and I'm going to pick up the underneath, I'm going to try to find about 4 to 5 millimeters. I'm going to turn the needle. If you notice, I'm letting the needle turn. And once it's in the tissue, if there's no tension pulling this away, the needle will actually stay there by itself. So I actually let go of the needle, and this is what's called doing a double bite. And then I come in here, and again, I use the radius of the needle to continue just to turn the needle out through the first side of our laceration. Notice how I've picked the needle up. I could also leave it on there. And again, pick the needle up in the middle. You adjust with using your pickup. So you have to start to use your hands because you don't want to stick your hand in on top of something sharp like this. You get to your other side, and in this side, you'd push to get yourself where you turn the needle. Again, it comes out at approximately the same distance. Do you see that? We're about half a centimeter, maybe a little more, back from the skin edge on this side. I'm going to come to the other side. Again, gripping the needle in the middle of the needle. I'm going to turn the needle to let it help me. Once it's through enough to see it, I can let it go, and I can let the needle turn through. Right. And that's a simple knot. Now, this is the simplest way to remember how to do simple sutures. If you were tying, let me move some stuff on here. I can't see all of what I'm doing. There it is. Sorry. And then, okay. So once you have your skin edges where you've got the tail, here's the tail. This is the long end where the suture is still attached to. Here's the tail. You put your needle driver in the middle of your two. And this is like a sewing machine. You'll go around the first time twice. Once, twice. You'll have a double loop. You'll grab the end. You'll switch your hands. Okay? And that puts your double throw in the middle. Now, you have to remember to keep your needle driver in the middle of the two strings. You go over one time after this, and you pull your sutures tight. Suture needle driver stays in the middle. Go over. Switch your hands. Come back over. Switch your hands. Come back over. Switch your hands. So for monofilament sutures, I'm going to move this, sorry. So for monofilament sutures, typically 5 throws, the first one being a double throw, and then a single, 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 single. That'll lock the knot down. And then if you were to hold up both sutures here, your assistant would cut them, and that would be a simple interrupted suture. Typically at the end of these, if you were sewing this on a face or a hand or a foot where there's a laceration, you would put all of your knots on one side of the laceration because that A, looks nice, and B, actually helps in terms of you want those knots on the side of the wound that has the best vascular tissue or the most vascularity, because that way you do the least harm to the tissue. Okay, so let's do that again a little bit quicker. Okay, so again, about half a centimeter back from the edge, turning the needle, let go, pick it up again, right? Pull it through until it's a fairly short tail, right? Use your needle driver to reposition, right? Going to the other side, just opposite. Turning the needle, pushing it through, pulling through, okay? Now, needle driver stays in the middle. 1, 2, switch your hands. 1, switch your hands. 1, switch your hands. 1, switch your hands. And the 5th one, switch your hands. There's a simple interrupted suture. Okay. And you would use this on lacerations that you make yourself, maybe skin incisions or a low tension wound where the skin can be approximated easily. You could use multiple stitches like this. The finer the tissue, the hands, the face, you use smaller stitches. So you'd use 5.0. This happens to be 4.0. This is excellent for hands and small tissue like that. So 4.0 nylon would be a good one for hands and faces and things like that. Around the eyes, you might use a 5.0 or even a 6.0 around the eyelids and so on. Okay. So I think next, Kayla, we had a horizontal mattress or mattress sutures, correct?
Yes.
Okay. So when would you use a mattress suture versus a simple? Mattress sutures usually when you need to cover a little more ground, and you also need to perhaps pull some tension on the wound. So I'm going to go over here to one that's got a little bit of depth to the wound, and you can see that. And I'm going to first do a horizontal mattress suture. Okay. So a horizontal mattress suture, we're talking about going horizontally in the skin this way. Vertical is this way in the orientation to the skin. So a horizontal mattress suture goes like this. We go in on our one side, again, using all the same technique. You would come back, depending on how much tissue you're trying to move, you'd also be using bigger suture. Let's say this was a traumatic wound that had some separation. I might be using 0 nylon instead of 4.0 nylon. Okay, so I'd be using a heavy gauge suture to pull tissue together. I would move back a little bit further, maybe even 3/4 of a centimeter from the skin edge, and I would put my first throw through like so. Go to the other side, and I would come out through the skin this way, right? And then come back in through the skin directly next to it to create a width of tissue that we're grabbing instead of just one little area. Okay. If you notice here, I'll leave this out. You can see there's a width of tissue there. And again, there we are. So I've tried to make an equidistant box with my sutures. I'll cut this so you can see a little easier. There. So if you look carefully, when I pull this, it pulls a larger area of tissue together. So again, once you've got that, it's no different with your sutures. Here's looking at it from the other way. Your needle driver goes in the middle. 1, 2 passes over. Switch your hands. 1 pass 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 over. Switch your hands. It's 5 passes. You can do 4 passes if you have a braided suture. Okay, so that's a horizontal mattress suture. So it's in. I'll do it one more time. We'll do it here. In. Okay. Then inside out. So you're going from so outside to inside the skin to outside the skin on the other side, outside the skin to inside the skin on the second side, inside the skin to outside the skin on the first side. So Mike, can you zoom in here? You notice my sutures are down in the bottom here, coming through the tissue, through the subcuticular fascial layer. So that's helping you grab the tissue and pull the sides together. So you're actually similar to a surgical staple there. Okay. So again, your needle driver knot technique is in the middle, 1, 2 passes, pull together, 1 pass, 1 pass, switch hands, switch hands, switch hands, switch hands. Okay. So that's a horizontal mattress suture. Now with a wound that's gapping like this, you might need to even do something more to pull tissue. And there's several ways to do a vertical mattress suture. And you're using different fascial planes, the subcuticular fascial plane, which is fairly near the skin edge, and some deeper fascial planes that are deeper. But a vertical mattress goes like this. It's the same thing. It's that same pattern, but instead of going this way, it's now going this way, up like so. So this tissue is a little harder to do, but if you notice, there's some pink tissue down in here, and I'm going to use that to help us do that, right? So a vertical mattress, there's actually blades in here.
Dr. Corey, what's the distance between the second and third bite?
So second and third bite.
So you took the first bite and then you want to cross
outside in on the first side, and then inside out, and then outside in, and then inside out. So which one are you talking about?
the inside out to the outside in.
So outside to outside, and then inside out, and then this one here.
Yeah, between those two, correct.
So that's going to depend on how, again, we're looking at a suture board here, but if this were, say, if I were doing a total hip arthroplasty or a hemiarthroplasty for a hip fracture or something like that, then I would have to judge the type of tissue, the size of the wound, the strength of the sutures I'm using. There's a lot of things that you have to judge. I could get these wounds close together with this 4-0 suture, but I'd have to put them very close together and take the tension off of this tissue. If I were doing this in, say, a trauma situation, I'd probably get out some 0 or some number 2 nylon, and I would pull this stuff together quickly because that's what you need to do in a trauma situation. So it's dependent on what you need. So I'm going to go back to the vertical mattress and kind of show you as well that the technique also helps you to decide. So having different techniques helps you, when you look at a wound, you can say, oh, that's going to need some tension relieved. What techniques do I have that can help me relieve tension on a wound so that the wound edges stay together? Because you want the wound edges actually to be sort of heaped up and mounded up like that. They heal better like that than anything else. You don't actually want them involuted like so. They don't heal well like that. So you actually really want to pull the tissue and get tension off of that. I wouldn't use that as a final stitch. I might use that to help pull a wound together and then continue, right? So I'm going to show you that in this case. So a vertical mattress suture could be used to pull tissue together. You would come way back here, away from the skin edge, way back, and you would come in at a certain depth, right? That's part of it, right? It's part of your suture. So I try to get as deep as I could, and if you notice, I cut through that second layer of tissue. So I'm doing a very, very deep suture here. And this allows me and I broke.
Dr. Corey,
Yes,
when
please.
you show this next one, can you show how to tie it off at the end a little bit slower? We have a few members asking.
Sure.
Thank you.
So a vertical mattress would go like this. You'd come in again outside in the skin, and you would try to get a deep suture. So you see how I went down through the pink layer as well? So that's pulling 2 layers of fascia. There's a deep vertical stitch. That's my outside in stitch. Okay. So I get down to my tail. Then I would do my inside out stitch. So I'm coming in on the other side, and I'm going to try to pick up that same distance. So I want my box to be square. So I go down to the same fascial layer, and I try to come out at about the same distance away from the skin edge. So I'm trying to think in squaring up this knot, as it were. Okay. So now we have 2 parts of this where it goes shallow to deep, outside in, deep to shallow, inside out. Now, since I'm outside again, but again, I'm doing a vertical mattress here, and I know I have to pull the skin edge together, I'm actually changing a little bit, and I'm going to come in at a little shallower level here, and notice they're lined up horizontally right next to each other, next to the wound, not sideways from each other. But they're different in that they're different vertical levels because one was deeper and one is shallower. So this turns this box into a vertical box rather than a horizontal box. So I'm going to pull this out of the way, and you can see the more superficial level, but you can't see the deeper level that's down inside. And as you pull this, you can see it pulls the top layer and puckers that nicely. So you get that skin edge pucker that we would want in closing this wound. So I can actually pull the tissues together with that suture. Okay. So you guys were asking, I'm going to lock this down. And so I'll do it very slowly now. So when you're doing a needle driver knot, okay, you'll want to have your tail that you're going to be cutting maybe as long as the needle driver back to the hinge, something like that. That's probably a good judge. A little bit longer is okay. It gets hard if it gets real long. But you want to put your needle driver in between the 2 different ends, the long end that still has the needle attached, and the short end, which we call the tail. So the needle driver goes in the middle, comes over towards yourself twice, and you grab the tail. And you switch your hands. You let go of the tail. You put the needle driver backward, right above the knot, right above the middle here. Stays in the middle. You go over, pick up the tail, switch your hands. Needle driver goes back in the middle. Bring the suture over the top of the needle driver. Switch your hands. Needle driver in the middle, over the top. Switch your hands. Once you've done 5, the first one being a double loop, 1, 2. And then after that, number 2 is once, number 3 is once, number 4 is once, number 5 is once. Then the proper way in surgery, I would hold both of these up in the air. And if I held them up like this, my scrub nurse would know I would want her to cut, or him to cut, both of those sutures. If I hold one suture up in the air, they cut one suture. Okay. So I'll do a horizontal, vertical mattress again. Okay. Vertical mattress again. So the box is vertical. So we start away from the skin edge. We go deep with our suture and let the suture turn, and we get into the deep fascial layer. Pick up the needle. That's outside in. Next, when we go in and we pick up that same fascial layer with our pickups, we turn our needle driver, and this is inside out. Okay. Next, we need to do an outside in on the second side, and this is going to be shallow. So this was deep to deep. So outside in, deep, inside out, deep. Now, outside in, shallow at the skin edge, and this would be four millimeters back from the skin edge. So again, this would be to pull a wound together that's going to come together, and also come in and make sure that the skin edge is together. And again, you can pull that together and get the skin edge together by putting tension on. Questions?
You have a question in the chat. Do you worry about the strength of the tissue with multiple sutures in the same area of skin?
Yes, and that's why you choose different suturing patterns, okay? So the next suturing pattern, we'll go to that, and this is the one that I like because I do a lot of work on the feet and the hands and similar. I like to combine the simple interrupteds with the horizontal mattress because it tends to spread forces out equally on surgical incisions, not necessarily the trauma wounds that I've done in the past. I had to use all of the different types of suturing patterns, and that's why these boards are set up to get you to understand even maybe stitches that are very, very difficult, flap stitches and plastic surgery stitches. But these simple stitches can get you through most stuff you'll see in an emergency room and in, basic ER medicine. These horizontal, simple interrupted sutures, horizontal mattress sutures, and vertical mattress sutures, and the variations of those, and this one get you through almost anything you need in an emergency room. So this last one I use all the time. I use it in almost every patient that I operate on. And it's a combination of, like I said, these simple interrupted sutures and the horizontal mattress sutures, except for it's faster than both, and it allows you to get good at both very quickly, and it spreads it out, spreads the forces out like you were asking about, and even allows for the body to swell a little bit without constricting the tissue, which would make me worry about the tissue. It's more about how healthy the tissue is going in. So a surgical wound that I create is healthier than a traumatic wound that happens because of a motorbike accident or a motorcycle accident or something like that. So how the tissue got injured is also important in knowing how to do your sutures, okay? So if the skin edge got beat up by a motorbike accident, oftentimes my sutures are very, very far from the edge of the skin. If it's a plastic surgery case, my sutures can be very close to the edge of the skin. So very different depending on if the skin's traumatized in those, then you use other ways. So this is what I do with a normal surgical incision that I created that I'm able to bring back without a whole lot of tension, okay? And let me go back, Kayla. I'm going to go back to the simple interrupted sutures I use in a subcuticular layer before I close. So in my normal closure is what's called a 2-layer closure. So I'll put a stitch into that fascial layer in a wound like this. And you can see this is a very surgical incision, very straight, very parallel. Everything's lined up very well. So I would put sutures in this layer of fascia under here. And this suture would be an absorbable suture. So this would be a monocryl, usually for me. A lot of surgeons use Vicryl in this layer. Vicryl is just a braided version of monocryl. I happen to like monocryl because I think it causes less irritation in the feet and hands where I work. So this is a subcuticular stitch, and you can see it's just a simple interrupted stitch, just like that, but I've put it under the skin so you can't see it. In this case, I would pretend that this is a braided suture that's absorbable, and you can see how it pulls my skin edges together, and it holds them together, and holds a little pucker. Now, if it's an absorbable suture, you would do your 4 or 5 passes, and your assistant would cut very close to the knot, so that would stay under the skin like so. So that would be the first part of me closing. Now I would put 4 or 5 or 6 of these in an incision this long under the skin, so the whole thing was approximated like so. And then to hold the skin edge without a lot of tension, whoever asked that question was a very good question. So how you do it is you spread these out, because the blood supply is actually coming in through, in most cases, through what's called random pattern flaps, meaning some of the blood comes in here, some of the blood comes in here, some of the blood comes in here. And so there's multiple blood supplies. It's not like a vascularized pedicle flap, okay? So this stitch, which I use all the time, is called a locking running stitch, or running locked stitch. And it starts just like a simple interrupted stitch. It's just a simple in and out, in on one side, outside in to inside out. Again, needle driver in the middle, 1, 2 passes, switch your hands, over the top, switch your hands, over the top, switch your hands, over the top, switch your hands, over the top.
There's a question in the
Yeah.
chat. They want to know how to hold the needle when they're doing their tie-offs.
Yeah. So it's everybody has to get comfortable with it. But what I've learned to do is I actually have the needle hanging just outside of the palm of my hand, like so. And I've learned to corral the suture such that I control it in my fingers. The needle hanging like this can't stab you, and it can't stab anybody else. So I work like so. Okay. Some people let it dangle further. I don't like that because it can catch on the drapes and so on, but I typically have it wrapped around one finger, usually something like this, and I have it hanging out the backside of my hand so I can control the suture like so. Okay. So from this,
Thank you.
that was a very good question, actually. Very good question. You have to get comfortable. So the other thing about this stitch is it allows you as a young doctor to actually learn how to follow yourself and do a suture pattern like this without assistance and get fairly fast at it, okay? So this suture, if you notice, if I had my gloves on, I could just be holding the other end of the suture up, right? And again, it becomes that same pattern. In through this side, so an outside in to an inside out. All you have to do is make sure that when you finish, you're actually coming through the loop that you just created. So you pick the needle up through the loop. And as the loop comes down, the loop closes. And once again, I'm holding, so I don't need, notice I'm not even using my needle drive, my pickups. My pickups are, I could put my pickups down at this point because my skin edge, I'm actually able to hold it up in the air a little bit by the needles. And I'm able to pass the needle and bring the loop towards myself. Pick up, bring the needle through the loop, let go of the loop, pick up the post. This is called the post, by the way. Right? And as you notice, I'm able to make a very uniform pattern. That repeats over and over again. Now, the nice thing is you don't have to pull these very tight. You notice I'm letting up tension as I go, and this is less tense than these, and yet the wound still stays together. So you can build in a little bit of slack into your suture line here, because you can assume patients are going to swell. Even if you do a perfect plastic surgery, there's going to be swelling because you created trauma. So the beauty of this stitch is that you can build in almost a springiness, like a Chinese finger trap, into the suture line. And there's an old saying in surgery, approximate, don't strangulate. So again, you can see how with very little, once you start to layer a series of these in, like a webbing, right? The skin edge doesn't come nearly as apart as it was before, right? And this is a great way to practice letting the needle turn, because I could actually do this. I'll show you. I'm going to cut my original knot out. So there's no knots right now. There's no anchor knot holding this together at this point. And that whole suture line stays together despite the anchor knot being cut right here. Okay. So there's no anchor knot, and yet the suture line stays together because the forces are spread out equally over this strip. So I find that it's almost as fast as doing surgical staples. You can actually control errors. Say the skin edge isn't perfectly shaped. Well, you can actually manipulate it with the shape of your sutures by changing angles, just using a little bit of geometry, which your mother was right. You're going to need your geometry, but you could actually take up a little more real estate on this side and a little less real estate on this side, and it actually changes how that knot lies down. Do you see that? Changes the shape of how the wound pulls together. So practicing on these boards and seeing what the different suture patterns do between the horizontal mattress, right? The nice one about this, particularly for someplace there, is it makes it very easy for suture removal. You literally can come in here and clip every third or fourth, and you're only pulling out 2 inches of suture. So kids really like this, patients really like that in terms of removing suture because it doesn't hurt them, and yet does quite a bit. Now, if the wound needs a little tension removal, you could come halfway down here, do that same suturing.
Dr. Corey, do you have a different suture, like a 2.0 at all in your kit?
Yeah.
I think you're using a 4.0. It's a little bit hard to see on the camera.
Yeah, I will. Mike's gonna go
Okay,
grab
thank you.
no nylon or big black nylon in the cast room. Any other questions while Mike's going to get that other one? So I was just going to show you a couple changes with that one again, just real quick. I'm just going to anchor it in. Okay.
Okay, so you did have a few questions.
Please.
The first question was, someone keeps breaking their suture when they're trying to tie a vertical mattress. Was she doing wrong?
Well, if it's the 4.0 suture, this is very small, okay? And if she's doing it in the place where I made the pink cut, those wound edges are too far apart. So do it in the one that I'm working on now and try to get a vertical. This tissue does not move like skin. So you actually would want to do vertical mattresses where you can actually get the wound edge all the way together. And so probably in this one over here that's very, very thin, or even practicing on these raised ones, so you can practice doing different layers of the tissue, right? So the purpose of the vertical mattress is so you understand that part of it is far and deep and part of it is near and shallow, picking up the skin edge. So it's just turning it over. So it's understanding the patterns and why you would use one. You use a vertical mattress suture and this inside out, outside in technique in suturing things like gut wall, and you use horizontal mattresses when you travel over bigger distances. So sometimes the different tissues that we're trying to heal or trying to anneal in these things, the suture patterns actually help us do that. Other
Perfect,
questions?
thank you. The next question is, what is the name of the suture pattern that has a single entry point and exit point, and the bites are running parallel to the length of the incision within the subcutaneous?
But it's the same as, it's essentially the same as what you just saw. So that suture pattern you just saw is less complex and less difficult to do than the pattern they're asking about. They're talking about a running subcuticular stitch. And again, to do that properly, you would do stitches underneath. You do subcuticular stay stitches like this, and you'd get a puckered edge like so. Okay, so that's a precursor to doing that stitch well. This to do a running subcuticular is a wound with no tension whatsoever. It's going to come together with no tension whatsoever. And so what you do is you actually come in at the vertical end or the axial end of the incision, and you come back in through the end of the incision, the apex of the incision. So the needle is kind of pointing right at yourself like so. Okay, you pick that up. And then you start a series of actual horizontal mattress sutures, but in the subcuticular layer. The trick here, and most people make this mistake, they'll move the skin tangentially when in fact you should pull the skin in line with the skin incision. You'll sooner or later you'll learn the tactile sensation of feeling the fascia in the subcuticular layer, but you're essentially doing a horizontal mattress on one side. And then you have to remember to try to stay square. So where that comes out underneath the skin, so if you hold it straight across, that's where you have to make the needle go back in, or else it'll make a wobbly thing. So you're trying to make essentially just like a sewing machine would make in a hem. So if this goes straight across there, then my next horizontal suture goes in here, comes out down the length of the incision a little bit further. Towards me. Yep, I get it. There it is, right? And then as you pull those together, that pulls the skin together just like the other one did, but it's all under the skin. So this would be used for cosmetics and so on. You can use them for orthopedic cases, and you can even have them where there's a loop in the middle and you could cut the loop and pull out one end and pull out one end. But this is something that you'll use later. I wouldn't recommend learning this as an early stitch because, again, learn to do the easy ones and the ones where the skin edge really comes together well. The problem with this is that if you don't start right, you won't end right. And if you get messed up in the middle, the whole thing gets messed up as you're seeing here. So what other questions? Oh, other suture. Yeah. I've got a 2-0 suture here, Kayla.
Okay, let me just ask this question real quick. What would invalidate using the uninterrupted technique versus the others?
Again, if the suture edge is going to need a lot of tension on it, because it's a single suture, you're more likely to pop that single suture. So again, you have to think about, I do this on surgical incisions because the incision wasn't there. I made the incision. So I was showing you guys again that sutures have memory. They come wound up in a case, and they stay wound up if you don't do something about it. So you just sort of have to take it like ribbon, sort of strip down the ribbon a little bit. And then after you've done that, you can see that stays out. Okay. And then, so when I'm sewing, if I'm sewing right-handed, I tuck the suture in basically double in my hand like so. So I have control of the tail of the suture. So Kayla, what did they want to see with the larger suture? Because now they can see the suture better. Which technique?
I think they were trying to see the uninterrupted locking.
Okay.
And how you made it lock.
Okay. Okay. Yeah. All right. So this is a bigger suture, so I can also show her a little bit why she couldn't pull the edges together. But to start this, again, it's a simple interrupted stitch. So it's outside in, right? and I'm single biting everything. Double bite would be trying to cross both sides of the wound in a single pass, and I'll show you next time. So there's a single bite. That's my outside in stitch, outside in, inside out stitch. Okay. Now we'll slow this down again. So the needle driver stays in the middle. 1, 2 passes over the top, grab the tail, switch your hands. Okay. Here's a trick. You can actually pull the anchor and it locks it. But anyway, needle driver stays in the middle, over the top. Switch your hands. Needle driver stays in the middle, over the top. Switch your hands. Needle driver in the middle, switch your hands. Needle driver in the middle, switch your hands. Okay? There's that. Now, the locking part that we were talking about, this helps spread those forces out. And this is also a way that we could, if we were worried, this doesn't invalidate. I've used this stitch on traumas before, but I do an extra step and I'll show it to you. So again, we go in, and this would be single bite, meaning I can reach across and get a good pass, right? The way that I locked it was I brought the loop, the full loop, towards myself, and I grabbed the needle through the loop. Okay, so then from then on, I could actually put my needle driver down, and because I can pull up on the skin edges, I can actually use my needle driver in my hand to continue. So as soon as I've put the needle in, pull the loop over the top, I'll show you again. So I basically have learned to hold, show more my hand is here, Mike. So I've learned to hold my hand up, so I'm holding my post, which actually helps me pucker the skin edge, right? I loop through, and all I literally have to do is reach and grab the needle. Let go of my loop. Pull it semi-taut again. Right? And I've learned that I sew it about 15 degrees towards myself, and it lays down a perfectly square knot when I do that.
And when you get to the end, can you show them how to tie it off, please?
Sure, absolutely. So again, you're
And we have a
right through
question.
the.
Oh, go ahead.
What was the question, Kayla?
Oh, they want to know when you're starting it, do you need to do 5 times?
Yes, that's your anchor point. So yeah, you definitely want to make sure. And this stuff's like fishing string. It's very slick, and like I said, it's got a memory. So you definitely want to make sure you're setting your to put your 5th one down. You lock that knot. You literally lock a square knot with the 5th knot. So yeah, with a monofilament, you definitely want to get your fifth throw in. So it's 5 throws. First one being a double, and then 4 single throws on top of that for a monofilament. And then this is how we would tie it off. So this is the last stitch. I'm down to the end, right? And all I have to do is actually let the loop go. Okay? Now, normally, if I were doing a simple interrupted, I would have a little tail right here, and I would just tie to the tail. But I have a double tail. That's okay. So I'll tie to the double tail. Right? Needle driver still stays in the middle, over the top. Needle driver stays in the middle, over the top. Switch your hands. Needle driver stays in the middle, over the top. Switch your hands. One more time. Switch your hands.
And what are the advantages to single or double bite technique, or is the double bite just easier to start with?
No, you definitely want to single bite everything. So what that means is you're going to position your needle. So a single bite means you're going to take one bite of the apple, meaning the skin. It definitely if until you become more advanced and more practiced, you'll fumble trying to go and try to figure out exactly where to start and get a good turn and everything else. So basically what you want to do is start with a single bite. You want to control the skin edge, and these little holes. Mikey, can you show them these little holes in the tissue here are great to practice, because you have to think about where to stop and start and how to use your other hand, right? So that's really the first technique, is how do I get the needle in there to the point where I can play the game. Remember the game Operation? I need to get in there and get the needle again so I can bring it back out and get it ready to do another thing. So that's the whole trick. Isn't can I get it across there in one stroke, but can I get the needle where I need it to go so that ultimately I can put a simple stitch across there or whatever it is. Okay, that was a good question. What else?
That was all of the questions that have come through so far. If you wanted to just show them the vertical or the horizontal with the darker.
So I'm going to do the horizontal mattress here on this axis, because it'll show up really nicely. Okay, so it's an outside in stitch, and then single bite. Inside out stitch. And again, you're trying to think of making a nice square box. So they're fairly close. This one's a little closer to be very strict, but they're close. So that's the first pass. Now, so we've done an outside to inside, inside to outside. Okay. So now we'll do an outside to inside. And just for sake of expedience, I'll single bite this. That would be a single bite. As you notice, the needle passes on one radius from this side to that side without interruption. That's a double bite, right? That's advanced. I've got a year or two of practice. Kayla made me stay up all night last night in practice. So there's what the horizontal mattress looks like before you've tied it down, right? Here's your horizontal mattress. 1, 2, 3, 4. Okay. So if you get short like this, you can actually tie with two hands. You can use your instruments. And you can see how it puckered the skin edge. In there, Mikey. And the skin edge has got that nice rolled appearance. That would heal very well. That little pucker right there. And so when you back up and you look, my horizontal mattresses at the skin edge are at least this far apart. You notice they're not super small. Mistakes that are commonly made for people who put their first stitches in are putting the stitches too close to the skin edge. That's what I want to draw my sharps. Let me grab another suture, sorry. Got that one.
While you open it up, I'll ask another question. When do you use braided suture?
I don't use, I use braided suture on larger wounds, and for things like tendons when I need the reaction, and for also it's been a long time since that, but like in chest tubes I would use silk. This is a 2.0 silk. It's been a long time since I've used silk, but this silk is used to create a reaction. So we use braided sutures when we don't care if there's a big reaction or whatever. You also use braided sutures in deeper tissues typically. One of the reasons you don't use braided sutures in the skin is because they pass from outside to inside. We got low battery here, 10%. The braided suture potentially is a risk for bacteria getting in the interstices or the little crevices of the suture. So something that passes from outside to inside, we don't want to have as many little crevices where bacteria could hide. So I don't typically use braid. Now, listen, if all I've got is braided suture, like when I was in Nigeria, you sewed with what you had. That's what you do. Okay, so the mistakes, common mistakes. One of the common mistakes is as well as abusing the tissue, really manhandling the tissue with grabbing and pinching. The other one is putting the sutures too close to the skin edge because you think you're closing the skin. Well, what you're doing is approximating the skin, and you want the skin to kind of heap up in a little teepee like so. That's actually really kind of what you want. I just dropped everything on the ground. You kind of want it like so, right? So the mistakes that are commonly made is people try to get too close to the skin edge and don't realize what they're actually doing is cutting the skin edge with the needle, and there's not enough fascial tissue to actually hold the suture. So when you put the skin stitch too close to the skin, you can actually cut out through the skin. So you want to be back a little bit from the skin edge. When you're doing horizontal and vertical mattress sutures, some of the mistakes are that in the horizontal mattress suture is that we put the horizontal part too close together. Well, you don't have any power in that. You know, you don't have, there's no separation there. So again, you would potentially, and this is to answer the previous question, this could potentially wound an area of the skin edge because you've got a lot of tension in a little area, and you may have to pull harder than you would if you had spread the area out over a bigger force. And so that's, again, you have to think in terms of physics and physiology. And if you're having increased pressure, point pressure somewhere, you potentially risk decreasing forward flow of capillary blood flow and things like that. That was a good question. Other questions?
Okay. Would you tie off every stitch when you're doing a horizontal mattress, or would you continue going down the wound?
No, you tie off. So every pass where you go inside every box, so every fourth inside out, outside in, inside out, tie it off. So it would look like this. In a wound like this, I would do a horizontal mattress here. And this wound would be a great one for horizontal mattresses, actually, because you could do it without flap stitches and corner stitches. A zigzag pattern like this is something that plastic surgeons do sometimes to preserve skin. It's called a Z-plasty, and the corners are at risk. So you could potentially close this with a series of horizontal mattress sutures like so. And I'm not going to tie them all off, but if you tied that off and then imagined they put these in your way to make it hard, so you have to switch hands and things. It happens in the real body too. There it goes. All right. So you would, this one would be tied off, and then you'd get to this one, and you would tie this one off, and so you could see how even in an irregular pattern, that would create a nice skin edge there with the heaped up edge and the approximated wound edge, and yet no suture. So there's area for the blood supply to come in tangentially off of the sides, even if you're getting a little bit of that and you're not crushing the skin edge, which may already be beat up by your knife or whatever created the wound. Questions?
Next question. What suture technique would you use for a stellate non-linear shaped wound?
So like this. So like so. Yeah.
Like
So-
that one, Landon?
So
Yes.
this goes back to a type of stitch similar to the subcuticular running stitch, except for it's referred to as a flap stitch. And it's similar to a horizontal mattress. You have to know that. And then the subcuticular stitch. So this might be a good one to add to this as a basic one. This would be one you'd use on face skin and other areas, flap skin, that you want to be very careful with, hands. So a wound like this that you're trying to approximate, but has lots of corners, the corners are problems. Things like this are where corners are a problem. Okay. So let's do this funny looking wound here and see if we can't get this to close like so. Okay. So what I would do here, looking at this, I would try to make a box again. So I would come in here like so, outside in. And this is called an Allgauer flap stitch, the hand surgeon. And then I would come in and get this other piece on this other side, but I would stay under the skin. And the reason I'd stay under the skin is because this is a very thin island of tissue, and more than likely it's compromised from a blood supply standpoint. So I'm going to be very, very gentle with that. But as we saw over here, I can pull those wounds together if I'm clever with my stitch pattern. And I think about the box that I'm creating. You notice I didn't tie that stitch down very hard, and that edge still stays together. And you notice there's no stitch on top of this very thin island, which would probably necrose that area. It's all, as you can see, right under there. So you can probably still get some perfusion down the pedicle, like so.
All right, so thank you for sharing that, Dr. Corey. It looks like we are approaching the end of the time. Did anyone have any last minute questions they had? Would you cut the horizontal mattress for the T-cut?
Horizontal mattress. Say again?
Would you cut, or would you do the horizontal mattress for the T-cut?
For this here?
Matt, for that one? Yes.
You could. So if I were to do it on this, I would think about it very similarly to the zigzag, right? So I would turn 3 pieces into 2 pieces. That was a great question. So I would come over here and turn 3 pieces. I would be using that 4-0 on this. I'd be using the 4-0. I would do something like this, where I would turn 3 into 2, 2 into 1, and so on. Now, you could also, and this is really on here for you to learn how to do a purse string, which is that Allgauer stitch 3 times. But I would do what you said long before I did this. And I've done it many more times than I've done this, but this is actually the technique that this little piece was added for. And this would be called a purse string. And that's how you do a belly button and a nipple and some other things.
Perfect. Thank you.
You're welcome.
Dr. Corey, I just want to thank you for taking your time. We know you're very, very busy, especially with all the teams that you work with, and we really appreciate you coming out to show us this, because it's important for us to get these skills.
Well,
Wow.
whatever you guys want to watch, let me know. I'd be happy to help. Love this stuff. This stuff's fun. It's a joy for me. So thank you very much for inviting me. Thanks for the suture kit as well.
Yeah, no problem.
On behalf of all of us, thank you. This was a collaboration between a lot of our clubs, so a lot of people here appreciate your time. I thank you for volunteering your time as well. So
Absolutely.
learned a lot of cool stuff. So thank you.
You're absolutely welcome.
All right, everyone, make sure you sign in with your different club forms before you head out so we can get our attendance. And other than that, have a good night and good luck on your minis.
Good luck, everybody.
All right. Good night, everyone.
Thank you, Dr. Corey.
You're welcome. Thank you very much.
Let's see, I guess if the clubs could repaste their forms.
Yes, I'm repasting it right now.
Thank you, Kayla.
Oh, thank you, Dr. Corey.